Welcome to part 3 of our Explainer series, based on the deep review published by Australian Dizziness Clinics. Today, we're diving straight into the neurochemistry and genetics of motion sickness susceptibility. If you're a vestibular physician, a neuro-otologist, an ENT trainee, or a senior vestibular physio, you're exactly where you need to be. We're going way beyond the surface today to figure out the hardwired mechanisms that make one patient severely susceptible to motion sickness, while someone else remains completely immune.
The core premise we're establishing today is actually pretty simple, but it is profound. Rational drug choice and taking an accurate, honest clinical history, they both flow straight from the biology. Motion sickness susceptibility isn't just some random situational response. It's a highly heritable biological trait. It acts as a prognostic variable, a treatment modifier, and, honestly, a vital bridge connecting conditions like vestibular migraine, PPPD, and post-concussive dizziness.
Okay, let's really dive into this, because here's a clinical paradox that hits the nail on the head as to why we need to master this biology. Why is it that scopolamine, a really old medication, remains the absolute gold standard for preventing motion sickness, yet ondansetron fails? Think about it. Ondansetron is one of the most powerful, widely used antiemetics in modern medicine. It works wonders for chemo or post-op nausea, but for motion sickness, it barely touches it. Why? Well, the answers to that, and why motion sickness runs in the exact same families as migraine, come down to 5 specific receptors and 35 genes.
Here's our roadmap for today's explainer. 1. The neurochemistry of susceptibility. 2. 5 actionable receptor systems. 3. Heritability and GWS findings. 4. The migraine brainstem overlap. And 5. Biological risk modifiers.
Section 1. The neurochemistry of susceptibility.
So to really grasp the pharmacology, we first have to map out the anatomical pathway of sensory conflict. Imagine a patient reading a book in a moving car. Their visual system says, hey, we're stationary, but their peripheral vestibular apparatus is actively detecting acceleration. These conflicting signals converge right on a brainstem cerebellar comparator. If that mismatch goes unresolved and the velocity storage time constant gets prolonged, it sets off a highly predictable efferent cascade. This cascade shoots straight through the nucleus tractus solitarius, the NTS, and the area postrema, and that's exactly what drives those classic autonomic emetic symptoms we all know: the pallor, the cold sweat, the salivation, and ultimately nausea and vomiting.
Section 2. 5 actionable receptor systems. Understanding this neural circuitry is absolutely crucial for rational pharmacotherapy, because the neuropharmacology of motion sickness relies on 5 highly distinct, clinically actionable receptor systems. Let's walk through them. First, muscarinic M1 and M3 receptors. These mediate nausea through projections from the vestibular nuclei straight to the NTS and dorsal vagal nucleus. Scopolamine beautifully and potently suppresses these pathways, making it our most effective single prophylactic. Next up, histamine H1 receptors. These gate labyrinthine signals toward the emetic center, so blocking them works great. Third, dopamine D2 receptors. They modulate the emetic trigger threshold, acting as conditional adjuncts. Now, what about serotonin 5-HT3? Well, ondansetron targets 5-HT3, right? But the vestibular emetic pathway relies way more heavily on muscarinic and histaminergic transmission than on serotonin at the NTS level. That's exactly why ondansetron is so weakly effective here. And finally, noradrenergic projections from the locus coeruleus mediate arousal. This perfectly explains why reducing anxiety or using SSRIs can actually improve a patient's baseline susceptibility.
Now, if we drill down into that histaminergic pathway, we uncover a massive prescribing distinction. First-generation H1 antihistamines, things like promethazine, cynarazine, and dimenhydrinate, these readily cross the blood-brain barrier. They actively reduce the gating of signals in the medial and superior vestibular nuclei and the NTS. Because of that, they're highly effective. On the flip side, second-generation non-sedating agents like cetirizine or efexofenadine, they have negligible CNS penetration. Reaching for non-sedating agents for motion sickness simply will not work. You absolutely have to prescribe a first-generation agent to get that required central effect.
To anchor this pharmacology in the neuroanatomy, let's consider the area postrema in the dorsal medulla. It acts as a circumventricular chemoreceptor trigger zone, essentially sampling blood-borne emetic stimuli. And this region is heavily populated by those dopaminergic D2 receptors we just talked about. So, in patients where central dopamine dysregulation amplifies nausea, and we see this particularly in those with comorbid vestibular migraine, using a D2 antagonist like prochlorperazine or domperidone targets this parallel emetic pathway.
It acts as a brilliantly effective adjunct when antihistamines just aren't cutting it.
Section 3. Heritability and GWAS findings.
Now, what's really fascinating here is that we need to reframe motion sickness. It's a hardwired, lifelong trait, not just a situational reaction to a bumpy boat ride. Data from the Twins UK cohort registry establishes that motion sickness susceptibility is incredibly heritable. In childhood, we're talking up to 70% heritability. That declines slightly to 57% in adult years, but it proves that pediatric and adult motion sickness are phenotypically related. They're just modulated across the lifespan by environmental factors like exposure history, habituation, and dynamic disease states.
And the genomic data backs this up flawlessly. A massive genome-wide association study, or GWAS, analyzed over 80,000 individuals and identified 35 independent genomic loci that reached genome-wide significance for motion sickness susceptibility. This is a complex, systemic, polygenic trait. These genes cluster around inner ear development, eye movement control, glucose homeostasis, and broader neurological signaling. But here's the real kicker. The sex-specific effect sizes for several of these loci were up to threefold larger in women than in men. This provides a rock-solid genetic basis for the sex differences in susceptibility we see every single day in clinical practice.
Section 4. The migraine-brainstem overlap.
That genetic architecture we just unpacked leads us right into one of the most common and vital clinical comorbidities you're going to face: vestibular migraine. Motion sickness and migraine don't just coincidentally occur in the same individuals, they literally share precise central circuitry. Trigeminal vestibular projections, serotonergic modulation, and those histaminergic H1 pathways, they are fundamentally common to both conditions. Plus, down at the genetic level, several risk loci from that GWAS data are actively shared between motion sickness and migraine, especially the regions implicated in trigeminal sensitization and ion channel function.
So, the crucial takeaway here is this. When a patient presents with chronic dizziness and a heavily elevated motion sickness susceptibility score, vestibular migraine absolutely must be at the very top of your differential diagnosis. Trait motion sickness is a premorbid vulnerability here. The release of CGRP during a migraine attack chemically sensitizes central vestibular processing. It lowers the threshold for sensory conflict nausea. And that's exactly why optimizing anti-migraine prophylaxis so often simultaneously improves a patient's baseline motion sickness susceptibility.
Section 5. Biological risk modifiers.
While genetics lay the foundation, dynamic, whole-body physiological states can independently and reversibly modify these hardwired risks. First up, the hormonal axis. Estrogen acts directly to sensitize cholinergic projections in the vestibular nuclei and the NTS. This perfectly explains cycle-dependent fluctuations and why oral contraceptives with synthetic estrogen produce sustained spikes in susceptibility. Pregnancy, especially that first trimester, dramatically amplifies risk through both estrogen and the direct emetic effects of HCG on the area postrema. Secondly, anxiety and panic disorders elevate risk by ramping up those locus coeruleus to NTS arousal loops. But on the flip side, pharmacological or CBT-based anxiety reduction can measurably drive that baseline susceptibility risk right back down.
To sum all of this up, these 5 actionable receptor systems and 35 genomic loci literally dictate the clinical history of the patient sitting in front of you. Coming up in part 4 of our Explainer series, we're going to turn our focus to clinical assessment and susceptibility across vestibular disorders. That's where we translate all this deep biology directly to the bedside questionnaire.
I'll leave you with this final thought. How will this neurochemical blueprint change your very next prescription? Are you going to ensure your patients get a first-generation antihistamine instead of a second-generation? Will you consider D2 adjuncts for your vestibular migrainers? This has been an Australian Dizziness Clinics Vestibular Physician Review. Head over to australiandizzinessclinics.com for the full literature review and the cheat sheet.